there are interprofessional consult codes and there's hospital telemedicine codes. Are people doing consults, hospital consults from their offices to try and avoid going into a hospital setting on somebody who may not need a physical examination? Dr. Gore, are you guys doing that at University of Washington?
We are piloting it. So I would say it has not become a regular part of our workflow, but we've prepared kind of a process working with the ER for how to do it. It accomplishes a couple simultaneous goals. Number one, it's safety for the patient, safety for the healthcare team, but also a big factor is to help the ER with this, so they don't emergency room for too long, so they have capacity for potentially for COVID patients. Right. So I would say we are piloting it, but we are not regularly using it. But we may be using it more in the next several weeks.
Okay. Dr. Spitz, how about your experience with both, whether interprofessional consults or telemedicine visits by patients who are in the hospital?
So in private practice, we often do interprofessional consults, but we never charge for it, nor have we been able to. This is something that I think our practice will look at more carefully in terms of capturing that, because certainly there are occasions when we don't need to come in for a patient, even pre-COVID. And now in the COVID environment, I am deliberately avoiding going into the hospital for consultations or even for rounds when a physical exam really is not required. There are platforms that are HIPAA compliant. The InTouch robotic platform is one such platform, but these platforms in my community are in limited locations, in ER only, for example, not on the floors. So what I have done for inpatient consultation as well as for inpatient rounding is to take advantage of the relaxation of the HIPAA requirement, and the nurse who is caring for the patient conduct a FaceTime with me and the patient on her phone or his phone, or even on the patient's phone. And this has allowed me to avoid my exposure or my additional exposure to that patient. And it has been, I think, a very efficient process and an easy process as well. Because in many of the consultations, even if you do have to go in and take care of a problem, such as an obstructed or infected stone, you don't necessarily have to see that patient in person before you schedule the procedure. And with an examination demonstrated to you by a healthcare professional at the bedside and a face-to-face communication with the patient and a review of the records and of the other diagnostic data, which is accessible to you by remotely logging into the hospital EMR, the first time you need to drive in and enter that hospital grounds is to meet the patient in pre-op holding and perform the procedure. And likewise, the next day, if the stent placement was straightforward and the patient's white count is going down and their fever curve is decreasing and they are symptomatically doing well, there's really not a need to round on them in person that next day. It can be accomplished telemedically. These are just simple examples from my own personal experience, but it just demonstrates how we can incorporate telemedicine to the inpatient setting.
Okay. And Dr. Rhee, how about yourself?
So in our system, the hospitals actually they're all private rooms. And so they're all equipped with cameras and a huge widescreen TV where it allows the patient to be seen in what we call an integrated video visit. There is a common area which is down in the hospital where consultants can actually do rounding telemedically through this integrated video visit through all the hospital rooms. The other aspect of this in terms of the inpatient setting is the ER. And so the ER, to Dr. Spitz's point, all of our physicians are equipped with iPhones that are compliant from an IT standpoint. And so these iPhones have been wonderful in regards to literally using whether for texting or for consultation on the phone or on video to be able to provide that access both for our emergentologists and our urgentologists. And finally, the operating room. In the inpatient setting, we have for the last several years really perfected an ability to do telesurgery where a surgeon does not even have to be in a surgical OR, let's say with a patient who may be COVID positive, to minimize, at least for now, to minimize that exposure. There can be ways where a consultant, a surgical consultant, can actually provide some of this care through a telesurgical means.